I'm Bali Titani. Thank you tonight. What has the COVID-19 pandemic revealed about our healthcare system as the country prepares for the national health insurance? That is the question we're tackling today. Joining me to dive into this is the chairperson of the Portfolio Committee on Health, Dr. Sibongiseni Dhlomo, public health medicine specialist, Dr. Nicholas Crispin, also consulting for the Department of Health on NHI, and Wits University Chair of Social Security Systems Administration and Management Studies, Professor Alex van der Heever. You can be a part of the conversation tonight. Tag us on Twitter at Newsroom405. WhatsApp your questions and your comments to 072-110-5584. Gentlemen, good evening and thank you for your time tonight on the Newsfeed Late Night.
Good evening. Thank you for inviting us.
Dr. Crispin, I'll begin with you. Looking at the pandemic and the opportunity that it offered for us to, I suppose, test the NHI system to see if it really works, particularly when it comes to the centralization of resources, the leadership that is required, the accountability that is required, and the equity with which we look to distribute our health services in the country, irrespective of whether you're able to pay or not at the time when you need that health urgently. Do you think we dropped the ball? Did we miss the mark?
Well, Thabo, we don't have an NHI yet. That's the whole problem. And so what we've experienced is the disharmony and disaggregation of the services, with lots and lots of different IT systems, different ways of treating patients, different interactions of both from one province to the other and between the public and the private sector. And under the circumstances of this very disparate way of dealing with our health system in different parts of the country, we've actually done surprisingly well. There have been, at the start of the epidemic, many different IT systems unable to talk to one another, very, very difficult to report on anything, and no standard way of communicating on basically anything. And by the time we got to the end of the first year, a large number of those challenges were dealt with, but even not only between the provinces, but between the province and the public sector and the private sector, there was far better cohesion, far better exchange of information and coherent reporting. There's still a very long way to go, and there isn't one single coherent system yet.
Yeah, I mean, just on that, I know you've raised this issue before that, for example, the capturing of biographical data was a big a disconnect between what the public sector was doing and what, for example, the private sector labs would have expected to see as information on the blood samples. Can you say confidently now that we've got an IT system that can speak to both?
Well, we still don't have everything working completely smoothly. You know, there's one thing having a system. The other thing is people learning to use the system and coherently and to use it all the time without any hitches. So I think we'd be naive to say that everything is running completely smoothly. But compared with what we started with and what we have now, and if we take just one example with the vaccine system, there are still lots of hiccups. And there's still lots of communication issues around the present small, I say relatively small, 200,000 vaccinations of health workers. But at least it gives an opportunity for us to get the nuts and bolts of that system working before the mass rollout actually starts, when the vaccines start to arrive. So the answer to the question is, do we have everything running smoothly? No, we definitely don't have everything running smoothly. But it is certainly running better than it was. And we are able to report test results and deaths better than we were before. And we're able to exchange information between provinces, amongst provinces, and between the private and the public sector far more efficiently than at the start of the epidemic. But that's just the data management within this response to the COVID crisis.
And that's just one part of it, and we're going to touch on the other issues as well, Dr. Crispin, in a moment. But Prof. van der Heever, I want you to come in here. If we look at the centralization of the system, which of course is a big part of what the NHI is going to be about, there will be a centralized fund with the national department pretty much having power to appoint, for example, board members, a power to decide on procurement, a power to decide on licensing and distribution and so on and so forth. Would you say we came up and rose to the occasion as far as how we handled this pandemic? Of course, the fact is nobody expected the pandemic. Nobody knew what the pandemic was going to bring. It was a new disease. I mean, doctors themselves were still trying to figure it out. So there was no particular way in which we could have tackled it in a manner that is uniform. But generally, on a broad scale, as far as the centralization system is concerned, what's your feeling, Prof. Heever?
So firstly, when we examine what doesn't work in a health system, you use that information in order to design improvements to the system. And the question is whether the national health insurance proposals bear any relation to the failures that we're seeing within the health system at the moment. So a system, as you design it, needs to have a distribution, let's say, you need to make decisions between what you centralize and what you decentralize in order to maximize your efficiencies. And when you decentralize things, you have to do it with an accountability framework that ensures that when people have the discretion to do things at a lower level of the system, they don't abuse that discretion. So currently, we probably have the worst mix of centralization and decentralization at the moment. And we do need to repair that. But the National Health Insurance Bill, as proposed, does not correct the flaws within the health system. It works from the premise that we must centralize procurement as a fundamental, centralize procurement, licensing, etc., and for the entire health system. And that is not how you cure the problems that we're seeing in front of us at the moment. And just to talk about information systems that have been very weak in this, we've had quite a long time in South Africa to ensure that we have an integrated information system and distinguish between that and procurement. Procurement, very often in health systems, you decentralize the decisions about procurement. You don't centralize them. But information systems, you can establish a legislative framework that ensures an integrated system without having a top-heavy organization that runs everything. So the point is, what should we do to deal with information systems and correct those? That is a distinct problem from proposing that we actually centralize everything. And the problem that you mentioned before of the minister appointing everybody and the kitchen sink in the National Health Insurance framework is one of the flaws that we have in many of our public institutions that has resulted in them being driven, their incentive structures being driven by patronage, operating through the political system, operating into political parties, in particular the ANC. But we are vulnerable to any political party exposing that vulnerability given the way that our constitution is currently structured. We cannot protect national or local structures from interference, corrupt interference at the moment. And the examples that we've got at national level as well as local level show us that we are not getting MECs put in jail. We are not getting people who are premiers put in jail. We are seeing people, the ANC itself is being split apart because there's an attempt to prosecute certain people who have been caught with their fingers in the till. Now, if that is the extent to which we have to go to get accountability into the system, we have a problem when we now say we're going to create another mega system in which we centralize huge amounts of funds in a single organization, as we see with Eskom. And we also have it with other funds, compensation fund on a much smaller level, very poorly run, very poor systems, no improvement over 26 years, no advancement in technology, in improving the benefits that are provided through the compensation for occupational injuries and diseases. So this is our experience at this point. We've had many experience in failed institutional designs in South Africa, but it's clear that we're not learning from them.
All right, Prof, we'll come back and we want to get a response to all that which you're raising and that which Dr. Crisp has been raising as well from the chair of the Portfolio Committee on Health, Dr. Sibongiseni Dhlomo. He's standing by. Let's take a break. When we come back, we get his reaction to this. You can join the conversation tonight at Newsroom 405. WhatsApp your questions and your comments, 072-110-5584. Seeing how looting happened of the COVID-19 relief funds, did it erode your trust in government's ability to protect the NHI funds? We're back in a moment. Stay with us. Back to the news feed late night, and our conversation continues. Tonight, our panel, Dr. Sibongiseni Dhlomo, Dr. Nicholas Crisp, and Professor Alex van der Heever. You can be a part of the conversation. Join us tonight at Newsroom 405 or WhatsApp your questions and your comments to 072-110-5584. NHI under the spotlight tonight, looking at our handling of the pandemic and this being seen at least as an opportunity to test our ability to centralize our resources and cater for the needs of those who desperately need health services in the country. Dr. Sibongiseni Dhlomo, let's get your reaction. I mean, when you hear that the SIU is investigating 2,000 shady PPE contracts worth 13 billion rands, and the procurement corruption is so high to the level that even at this point there's no accountability to an extent, no transparency. No one has really been put in orange overalls yet at this particular time on this looting that has happened here. Is that a cause for concern for you as far as the NHI structure is concerned?
Thank you, Thabo, and thanks to your viewers. I don't think that is what actually I would really focus my point on, because when those who are opposed to NHI raise the issues of corruption, and immediately we indicate to you that there's an SIU, so I can't go ahead of that. All what I could actually indicate is that this pandemic caught us at the time when the country is putting together building blocks of the NHI. Among other things is the Presidential Health Compact, which talks to issues that Dr. Nicholas Crisp has spoken to, issues of infrastructure, improving the human resource, improving digitalization of information. That process of the NHI bill is still with us on the committee that I chair in Parliament. I would like to indicate that the process is at the level where now we have listened to the country-wide public hearings, and we are now going to be considering in the next 3-4 weeks those institutions that have indicated their desire to come and make presentations to us. But this pandemic has shown us that there are certain areas where we can work together. The issues of the hospitals, hospital services, there was a very good synergy between both private and public. And going forward, those are prerequisites to see that integration of the NHI. But when you then say, is the corruption part of it? Is not. In fact, we also are actually opposed to this matter, the issue of corruption, and there are systems in place to deal with that. If there is a thinking that NHI will be one of those areas where there will be a space for corruption, we have things that there's also a particular focus body that is focusing on looking for corruption within the health systems. That is why, among other things, people who probably were trying to have their hands on the till are actually being investigated. And now that is about corruption in the whole area where we are looking into it. Yeah. But that should not deter us in actually putting in place the building blocks of the universal health coverage in the country.
But as Parliament, I'm sure you're aware already, I mean, you've already mentioned that there are detractors of the NHI, and there is this trust deficit between a private and a public sector. In fact, there are some who have made submissions to you that they hope that this collaboration between private and public sector, for example, in the Western Cape, is not a funny way of sneaking NHI via back door. Were you at all embarrassed by the fact that while we were trying to beef up our health system, there are people who went to the till and they stole money? And as Parliament, what view did you take to that, and how this erodes the trust in government in particular to protect the NHI funds?
We discourage that. We condemn that issue of actually embezzling money to for our own personal gain, because NHI will also not be going for that. It talks about the financing system of everybody, both poor and rich. Now, no one would then be given a space and time to have money kept one side for that person. So we discouraged that and we condemned it strongly. And that is why we support all systems in the country that are actually investigating those. If the system that is, we are putting together a social solidarity program of the NHI, will be actually be tampered with people who would really still want to steal. That also we are saying there will be systems in place, and they are already there, that will safeguard that the funding so collected for the public use, for the public good of all citizens in terms of health, should not be tampered with by corruption and theft. That we actually condemn, and we hope, and we are really looking forward to the SIU and all those bodies that are investigating to really get to the bottom of it. And people who actually, now I can't determine what the prosecutor, what the judge must, and when must it send people to be on overalls. But I'm happy that the process is on, and people will actually, if they are found guilty, will go. There's no one who can actually say that is not a right way to go. We are, but we can't predetermine right now as to why are they not in overalls today and yesterday. That process is on, and it will take its toll.
The big question is also around transparency. Yes, accountability is one, but transparency is also another. Do you think we made a mistake by putting in place emergency procurement regulation at the time, which in a way reduced the PFMA requirements for PPEs?
Among other things, that is why now on the procurement of the vaccines, we actually are happy of the centralization of the procurement of this process, urgent as it is, because you can actually be able to count and tell how many hands have actually touched which process of this. But if you spread it right across the whole country, like we learned from the PPEs, and now we have PPE processes and people to be prosecuted, we think it was the right way to. And I'm glad that even in the issue of the NHI, it talks about the single purchaser of the services and also getting that distributed in a way that is. So I think this is the right way to go. We learned from it. The emergency procurement that was done countrywide, but every other person opened us up to what we have now seen as a widespread corruption here and there. So we would hope that we would support this centralization as we are actually having it currently on the procurement of the vaccines.
Dr. Crisp, you maintain, though, that it's not a Department of Health issue. You're saying it is a systemic issue with all departments actually getting affected by this. Just share your views on what you think, your thoughts are around the fact that emergency procurement regulations were put in place as opposed to centralizing the purchasing of PPEs.
Well, my view is that the decentralization and the lifting of some of the constraints that we saw in the normal procurement process was a mistake. And I think we've heard Treasury themselves comment that it didn't work and it shouldn't have been done. Those are completely different issues from what the NHI bill says and what we are trying to put in place with these building blocks that Dr. Dhlomo was talking about. If we just take one of them, never mind the purchasing of healthcare, which is the fundamental objective of the NHI, is to have central purchasing of health services from public and private providers. That aside, what Prof. Heever was talking about, the procurement, the centralization of procurement, is not the centralization of purchasing. It's the centralization of setting the prices and the procurement. So making sure that products that are available to be purchased by the providers, to be bought by them in the delivery of their services, have got prices that are acceptable, the standards is acceptable, the quality has been checked. These are known providers and not just every Tom, Dick and Harry bringing in container loads of goods that have not been checked and have not been through the required regulatory processes. But there's no ways that the NHI is aiming to actually physically buy and distribute everything, whether it's medicines, vaccines, whether it's sheets for the hospitals. None of that is supposed to be centrally purchased. It's supposed to be centrally procured, and there's a distinction made between that procurement of identifying and putting on the central registers, including the formulary when we refer to both the medicines and the devices. And then the providers, both public and private, who are accredited by the National Health Insurance, will be able to purchase from those people who are on those registers.
Right.
There's a long way to go before things like that are possible, But in the public sector, there's already an element of that was taking place and is now back in place.
Now, Dr. Crisp, I want us to talk.
There have been many mistakes made.
I want you to expand on that.
Acutely embarrassing what has happened.
Yeah. I want you to expand on that when we come back from the break, because I want you to talk about what went wrong as far as the service level agreements are in place. Only 4 state patients were treated in private health care, right? So I know you were involved to an extent in the negotiations of the collective tariff structures. So we'll talk to that when we come back from the break, so that you can expand a little bit on what system we should have put in place. We're back with you in just a moment here on the Newsfeed Late Night. Give us your thoughts at Newsroom 405 072 11055. Thanks for staying on with us here on the Newsfeed Late Night. Our panel conversation continues now with Dr. Sibongiseni Dhlomo, Dr. Nicholas Crisp, and Professor Alex van der Heever. A single system of ensuring that there is equity in access to health services, almost a one-stop shop where you will get the same kind of service, the qualified capacity that you need of expertise, as well as the treatment that is equal, and products that are tested that you know they do work. Dr. Nicholas Crisp, you were saying, but the biggest challenge here was to be able to get a collective pricing structure that will be applicable during this time of the pandemic in the public and the private sector. Only 4 public sector patients were treated in a private health care system in the Western Cape. Why?
So during the first phase of the pandemic, it looked at one stage as if the public sector was going to be overrun. And at that time, the private sector was not experiencing that at all. In fact, their hospitals were empty. They were losing money. Many practitioners were severely impacted by not having patients. And so it seemed an obvious thing to do to look to the private sector to take up whatever capacity or provide whatever capacity, service provision capacity might be capable. It's way more complicated than it looks, because the private sector is not a single homogeneous sort of company that you go and talk to. Hospitals work completely independently from the practitioners. Even the physiotherapists and other therapists work separately. So do the laboratories, so do the radiographers and radiologists and so forth. So there are many, many players who were involved in trying to formulate a single price to purchase care in a bed. It's not just going to the hospital groups and saying, provide us with care. And that took a lot of time, and I must give credit to the Western Cape Department of Health. They did a huge amount of work together with all the various players. Our job nationally was to find a price, and it's a composite price of a number of different players to provide for an inpatient care bed. Now, again, the definitions were different from what is in the normal arrangement in the private medical schemes, where they talk about ICUs, and they don't really have high care beds. And we were looking in the public sector for a new kind of a bed called a critical care bed, which is sort of a mixture between the ICU and the high care beds. So there was nothing that was standard. There was nothing completely tested in the past. And credit to all the players who came to the table. Everybody said, we're prepared to do this at cost. We will put our weight behind it, and we will do whatever we can to reach an agreement. And agreements were reached at the point where the huge epidemic in the public sector started to slack off, and the pressure was less. Then, of course, when the second phase came and the agreements were in place and it was possible to use those agreements, the private sector was overrun as badly as the public sector. And everybody was just completely, head deep in this terrible pandemic. And so there wasn't really the exchange of patients and the referral of patients that had been planned for. It doesn't mean it wasn't necessary to have the discussion, and it doesn't mean we didn't really learn a lot from one another during that process. It's not how one would do it for the NHI. It's not how you set prices. And what it did teach us is that we are capable of sitting around a table and finding a solution to a problem. But the design of what we did at that time was for this pandemic. It was not for the NHI, although obviously we're going to hopefully have those same collegial discussions as we move forward to find the solutions when we move towards the NHI.
Professor Alex van der Heever, these are building blocks to a service provision capacity type of model, and certainly this has sparked the right kind of conversations happening between the public and the private sector. If, for example, you look at those service level agreements that were put in place, what is your feeling?
Well, these service level agreements are far from a long-term sustainable agreement. So I don't think the pricing would be accepted under normal circumstances. They basically discounted it substantially for the pandemic. The other problem with the setting of the SLAs was that it took months for them to be established. Now, put aside the fact that the beds were not necessarily used, because mostly this was a negotiation around critical care beds instead of general ward beds. And part of what needed to be done was to make sure that we had general capacity for general ward beds as well, with oxygen supplied to people. And that would have been something very useful to have as a shared response overall. Now, my problem with how long it took was, if we had to look at an example, I've spoken to the people in Chile. In Chile, they have exactly the same kind of configuration of public and private as we do. What happened was they realized that this is going to be a constraint going forward when they hit a big wave, and they negotiated immediately a shared service arrangement in March of last year. It took us till July, and it had to piggyback off the Western Cape's negotiations effectively, and I think that was too long, and it's unclear as to why it needed such a long time. But if we have to look at another centralized purchasing arrangement, the whole vaccine strategy. The vaccine strategy was very much in the national government's corner, and it did nothing during 2020. And this is one of the problems. When all your eggs are in one basket and the team doesn't do their job, you're basically stuck. And we've really been harmed as a consequence of the delayed vaccine strategy. And I'll just give you one example to indicate how far back we are. There were no discussions or negotiations with Johnson & Johnson, for instance, in 2020, no adequate ones. Johnson & Johnson in January was announcing it's going to export its entire domestic production through Aspen Pharmacare to the United States and Europe in 2021. And only subsequent to that late end of January were other negotiations introduced to divert some of those doses to South Africa. Now, that's not the time to start the negotiations, and we still don't have an adequate clarity on a rollout or ground game for distributing the vaccines. Yeah. That in itself is a critical part now of the pandemic strategy, and it's not adequately in place, poorly negotiated and discussed, and it's just hard to understand what people have been doing.
Yeah. Prof, one would argue that and say, well, that's not a question necessarily that would say the NHI system is not going to work, but probably it's a question of leadership. If we would have to get the right people in a leadership position to lead this centralized procuring of health services.
It would be the same people we've got now. What you do when you design systems is that you have to design them so that that you're institutionalizing incentives all the way through the system to perform. So we had the earlier discussion on corruption. Corruption is only a proxy indicator of massive poor performance when it's so endemic and so ingrained and so deep and widespread as we have it in South Africa. Any organization that demonstrates the level of corruption we have now can't be performing generally. Even if the people who aren't stealing things aren't able to perform at the level they should. So when we redesign a system, you have to reticulate and distribute powers and responsibilities and accountabilities throughout the system to ensure that everybody at every part of the system wants to perform and can't steal. And that's not in the NHI bill. I mean, it's in somebody's head supposedly, but it's not in the bill, and it's not that institution. So we have no guarantee that an organization or series of organizations is going to be constructed that will institutionalize performance. And so the question of centralization is one issue. The whole reticulation of accountabilities is another. And those are things that are big discussions. You know, there isn't even a single policy paper on any of that I've discussed. There is no assessment or analysis of why our hospitals are failing. We don't even have proper figures that are produced, even in this pandemic, of the case fatality rates by hospital, which are deliberately not made public, so we can't see which hospitals are appallingly run, particularly in the Eastern Cape. All of those issues are absolutely critical in a discussion on performance. I can't tell you now how bad one hospital performs relative to another, and I should be able to. In the national health system in the UK, I can, because they publish that information. In South Africa, we keep it hidden, and we will continue to keep it hidden because it's not in the interests of people to let us know how they're performing. And so those are parts of the accountability system that we need to design in, and there is no discussion of that.
Dr. Sibongiseni Dhlomo, jump in to that particular issue. When you look at the NHI proposals, we're not saying, of course, what we saw now is NHI, but when you look at the NHI proposals, does it speak to institutional performance and institutional accountability? Are there policies there that will address that?
Thabo, what is critical is not to lose the objective of why we want this universal health coverage. By the way, this is a wave that you cannot stop right now. It's not just South Africa, the whole world. I mean, this is a World Health Organization policy statement that everybody should be looking for, supporting everyone in his or her country, the rich and the poor. I mean, this dates back from 1978. Alma Ata Declaration talks about health for all. For year 2000. Year 2000 has come and gone, and we haven't in the world got that universal health coverage. Now, even countries that are advanced in terms of universal health coverage, UK being one of them, and Germany, they are still having certain things that they have not put in place. Ours will be a different one, but it takes from this principle of universal health coverage. I'm saying now we don't see NHI in the country because we don't have it. And that is the reason why. And I could actually say, I don't know how you missed out, Thabo, that on the second wave of the COVID pandemic, the public health facilities were actually assisting the private healthcare sector when they were overwhelmed by actually patients that were there. We actually big numbers of patients being admitted in hospitals. We visited as a portfolio committee to oversight in the Eastern Cape, in Gauteng, and KwaZulu-Natal, and we visited both private and public health institutions, and we got a good report, and we could actually observe how they were trying to synergize and work around the challenge that they had faced. So as we sit in the country, we actually recognize that we have a challenged public health system. Of course, we do also have a very challenged private healthcare sector. There are patients who get discharged from these private health institutions, sick as they are, because they don't have enough money to continue paying. And you don't stay in the private healthcare sector if you are poor and if you don't have money. And therefore, we are addressing to say no South African should be left out there because they don't have enough money to pay and therefore not be treated. And that while we are observing challenges in the public, there are also challenges in the private health. We are looking for this universal health coverage. It will not be a flying aeroplane on the very first day. We are putting building blocks that might take 10, 15, 20 years to mushroom into a very strong universal health coverage system in the country. Many other countries that have gone this route have not actually had a shortcut and a silver bullet that gets them right there within 5, 10 days. It doesn't work like that.
Because of the segmentation of the private healthcare system in general, as Dr. Crisp has alluded to, do you foresee the NHI having difficulty, for example, contracting particular service providers, specialists, doctors in particular, who, for example, the hospital might come into an agreement with the government, but they are private individuals and their services are therefore rendered on those bases. Do you see that being a challenge for NHI?
I might talk a different language in 3 months' time when we have held all the private specialist groupings coming in to make presentations to us. I hope not, because this issue of social solidarity, where we are actually saying the issue is not about money, but it's about saving lives and supporting everybody else. We still have to be convinced that they will not be supporting. I envisage and I'm confident we'll listen to actually what they are presenting, and we need to actually find a common ground as South Africans. And of course, this may not mean a big profit in the pocket of the private specialists and the private institutions, but if they are willing and are available to support, because what it takes is that you need to actually take from people who can really afford. I mean, take, for example, Thabo, you have a domestic worker in your own house. You have a medical aid you've taken care of with your family. You don't care what happens to your domestic worker. Now, this, just that there in your own house, it now says to me, I need to fork out more so that my domestic worker can also get a quality of life just as good as myself if I need her to come back to work the next day. Same with my gardener. So it will mean some of us who can afford must be readily available to fork out more to assist the poor of the country, because there will always be poor people around where we stay and live.
Right, Dr. Sibongiseni Dhlomo, Dr. Nicholas Crisp, and Professor Alex van der Heever with us tonight. You can join in the conversation on Twitter. Tag us at Newsroom405. WhatsApp your questions and your comments, 072-110-5584. We're back with those questions in a moment. Stay with us. Welcome back. You're with us here on the Newsfeed Late Night, and our panel conversation continues now on NHI, as well as, of course, lessons we have learned during this pandemic that could be applicable to that particular structure of providing health care and making it accessible to all. Dr. Sibongiseni Dhlomo, Dr. Nicholas Crisp, and Professor Alex van der Heever with us tonight. Professor Alex van der Heever, let's talk to that question then that has been raised. Health service provision for all. The fact that the private sector continued business as usual. Do you see that as a shortcoming?
I think that is a problem. So universal health coverage strategies don't involve the centralization of everything. That's just one very narrow and unique approach being considered in South Africa. In most cases, health systems involve a plurality of structures which are integrated through legislation and through financial transfers. So the issue of ensuring equity across all systems is a necessary design requirement of our system. And it's important to note that we've introduced no institutional legislation for our health system since 2003. We've done nothing, basically. National government hasn't used its legislative capacity. It hasn't used its conditional grant structures, hasn't used any of its powers to create an integrated system between public and private. So these systems, and there are many examples where we can basically integrate our public and private systems in an efficient manner, and in a manner in which we can implement incrementally rather than create some idealistic construct that maybe we will achieve in 2030 or some other year in the far distant future that nobody can be held accountable for. It's important to note that the current proposal, for it to actually happen, requires that we effectively introduce substantial taxes to substitute for the private sector expenditure and add more in order to put it in one fund. That's really what the proposal entails. That's not feasible and possible, and I think nobody here is going to say that it is possible. But if you don't do it, you can't have the structure that is being proposed. And the structure that's being proposed is the only place where we will get our basic health package institutionalized and protected by government will be through the public system. And there isn't enough money in the public health system in order to do that, and it cannot raise the funds to do that. You have to have a cooperative approach between public and private, and you cannot raise the funds being spent privately and put that in the fiscus and assume that that's going to buy everything. So this might sound a bit technical, but this is the technical problem created by a really, really poorly conceived design. And so what it blocks effectively is the universal coverage strategies we could have within 5 to 6 years. Now we can't have them because we're waiting for nirvana, which can't happen institutionally nor fiscally. And those discussions aren't being had in a coherent manner. People have made a very narrow decision in 2007 in which they want to create a so-called single purchaser, and they've retrofitted every single proposal back into that design, no matter what, against all the evidence of how you should design a health system. So my problem is, you can talk about this idealistic system as much as you want. It will never, ever happen. But my big problem is that in the meantime, nothing will happen.
Well, the chair saying it's a moving train, that You cannot stop, Prof, saying whether people are detractors or not, this is a system that is going to be here, and it is here to stay to provide equity to healthcare services for all, so that we have this notion of a health system that caters for all, not for some, because what the pandemic has taught us, that if it only caters for some, then we all fail.
Exactly. But the point is, what design gets you that? The design that's proposed doesn't get you that. It pretends to, but it doesn't. So the question is, what system gets you that? We can't leave our system the way it is. But my concern is that all the things, and by the way, a lot of these policies have been discussed and the proposals are tabled on how you would achieve this in reasonable time. The issue is that government is not doing any of the incremental changes necessary to introduce harmony between the public and the private sectors, and to introduce equity and ensure a better and evolving model of universal coverage. None of that is being done while people wait for this perfect system. And that's the problem. Most systems actually grow and develop incrementally. They don't just suddenly, you don't just have this huge exponential leap to some fantastic system. It doesn't happen with health systems.
Dr. Crisp, it doesn't happen. A huge exponential leap is not something that's going to happen. Incremental changes, Professor Alex van der Heever says tonight. What do you say to that?
Yeah, thanks. Look, there are a lot of things that Alex has said tonight that needs to be challenged. And, you know, he makes statements that are not correct. If you read the National Health Insurance Bill and you don't read the amendments to all the other pieces of legislation that are proposed with it, you will miss many of the nuances of the reorganizing of the levels of functional responsibility and accountability. And just because he doesn't agree with it doesn't mean that it hasn't been discussed. He's just said now that there are policies, but in his previous, a moment ago, he said there hasn't been discussion about these things. I mean, the statement that nothing is being done, it's a very broad statement, maybe not as much as Alex would like to have done, but the health market inquiry was released. Then COVID came while there was discussions going on about how to respond to the health market inquiry. There have been many meetings in the Department of Health on what to do about it. There have been meetings with the Compensation Commissioner as well. There are several meetings and a forum with the Council for Medical Schemes. The Council of Medical Schemes has got a forum with Treasury and various financial institution bodies to discuss some of those reforms as well. So just because, you know, they're not moving as fast as we would like them to move does not mean that nothing is being done. So we must be really careful of these general statements about nothing is being done or everything is wrong. He is right, Alex is right, that we need an incremental change to our health system. But that incremental change has got to happen on many fronts over a long period of time, but quite fast in the beginning and on certain fronts. If we don't get coherence between our provincial administrations and our primary healthcare system, we don't have a foundation on which to prevent people getting into hospital. But if we don't already start talking to the private sector about hospital care and how we're going to pay for and charge for hospital care, we'll have the same problem. And it's not true to say that the National Health Insurance is expecting to raise a whole lot more taxes. The bill says very clearly that there won't be medical aids. And the money we would have spent on our medical aids, the same bill says that that money will be raised in taxes. And there are proposals, which are not for the Health Department to determine, it will be for the Treasury to determine, of introducing a payroll tax as one alternative mechanism to raise the money that is currently going voluntarily into medical schemes. Now, whether you agree or you disagree with it, you can't say it doesn't exist because it's in the bill. And it's been debated in the many committees and the many hearings that Dr. Dhlomo was speaking about just now by people, and it's about to be debated in Parliament. So we will step back for now. We will hear the inputs. People have strong feelings both ways, and we will hear what comes out of the process. I agree that there are improvements that can be made to the bill. There are issues around governance which are not as strong as they need to be, and there's not enough overt requirements for transparency. I don't disagree with any of that. But there's a process that is running at the moment. To carry on bleating about the past and saying that because the past was such a shambles and we're currently in such a mess does not solve the problem for the future. And we definitely can't leave the service like it is. In the 25 years since 1994, or a little bit more than 25 years, what we have seen is an ever-increasing and ever-complex private system and a deteriorating public health system. You have to put the brake on it, and you have to change it. There's no ways it's sustainable, and we've seen that during COVID.
Yeah. Did we manage to fix any of the hospitals, and to what extent?
Yes, we've managed to fix a lot of things in many hospitals. And one of the classics is the comment that Alex made just now about oxygen and general beds. During the negotiations, we negotiated general beds as well as critical care beds. And it was around oxygen. But oxygen is not something that, for COVID, that is the same oxygen supply and the infrastructure that was installed in public or private hospital beds. In the public sector, just about all the hospitals have had to redo their oxygen supply. Many of them are significant, major resupplies, with bulk storage tanks being installed in many of the urban areas and shifting the bottled oxygen into the rural areas, changing the transport routes. There's been a massive exercise. We're not talking about trickling oxygen to a few patients through nasal oxygen here. We're talking massive quantities of oxygen that we've had to go into the industrial supply as well and use industrial oxygen to back up our normal medical oxygen supplies. There have been ward refurbishments that have taken place during the COVID. There have been hospitals that were being built and were incomplete that have been completed, or parts of them completed, in order to pick up the slack. So, I mean, we can list them, and those are the kinds of questions that Dr. Dhlomo and his committee deal with in Parliament every week. So there's not nothing going on. The Department of Health and government probably don't convey this information as well as they should to the public, but there's a good deal going on. Whether it's enough, whether it's the right stuff, or whether we should be doing different things, those are all debatable.
All right, Dr. Nicholas Crisp. Let's take some of the WhatsApp messages coming through tonight. Lessons from the COVID-19 pandemic, from Tapa saying the government should be serious with the speed of decentralization of the medical infrastructure to all provinces, and also continue health education on all, so they can continue to follow COVID protocols. This one from Cuban saying, it is critical for the population to know the correct way that the NHI will work. The NHI is about the sustainable future of healthcare in RSA. It is unfortunate that detractors of NHI, when given airtime, use narratives that are incorrect and false. Thanks, Cuban, and thanks to our panel tonight. That was the chairperson of the Portfolio Committee on Health, Dr. Sibongiseni Dhlomo, Public Health Medicine Specialist, Dr. Nicholas Crisp, and Wits University Chair of Social Security Systems and Administration and Management Studies, Professor Alex van der Heever. Thanks to you for joining us tonight. We continue next. The tribute paid to jazz pioneer, jazz artist Huma Sigela in an exhibition of new photographs that were on display at the market. That's what we talk to next here on the Newsfeed Late Night. Stay with us.